So just as a reminder that nothing of what we say is meant to establish any kind of patient-doctor relationship, even if you are one of our patients. Whatever we say is not should not be construed as medical guidance, medical advice. So there's no patient-doctor relationship being formed during the course of this live episode and this conversation. So please mute yourself so that any kind of background noise that might happen in your environment doesn't disrupt the recording. And then we're going to tackle some questions that have already been posted on the Patreon page. You can also feel free to post questions in the chat, and you can also feel free to raise your hand on the Zoom, and we will call on you and you can ask a question live. So with that, let's get started. So one of the questions that you said that you can easily answer, so it'll sort of jumpstart us, is an update on the rapamycin trial, because I'm actually finding that the rapamycin has been helpful for a lot of patients.
Sure. So I have to limit this a little bit because it is research, and we don't go over results till we're published. So that said, there's about, I think it's 45 patients or 50 patients enrolled. We're still enrolling. It's open. Um, and Dr. Gottschalk, Gunnar Gottschalk, the co-investigator, has spoke to him a few days ago. Um, the the baseline labs, I assume everybody knows the trial, but why don't I give a 25-second summary? So this is a trial looking at a dose of rapamycin that's derived from some clinical trials of about 6 milligrams a week. The reason to use it is that it promotes autophagy, which is deficient as we get older, and we think deficient in our patients. And it does that by inhibiting something called mTOR. So they discovered a protein called ATG13, which was inversely related to autophagy. When the protein is high, autophagy is low, and they confirm that in animal models, and then they see it in ME/CFS patients. And I believe they also looked at long COVID patients compared to so-called healthy controls. So the trial, the biochemical aspect of the trial is looking to see if dosing decreases that protein, which would mean that autophagy is going up, and then correlate that with questionnaires that are completed every 4 weeks to see if a patient is noting improvement that corresponds to the drop in the protein and the rise in autophagy. So far, the baseline lab work, which means before anything was started, we are seeing abnormal ATG levels, meaning consistent with the hypothesis. And the first few lab runs are showing a decline in that. I can't give you a percentage of patients because I don't know it, and I'm not supposed to say it anyhow. But we're seeing it consistent, and we're seeing changes in the questionnaire answers. Even when the patient doesn't say they feel better, their questionnaire tools, the measurement tools, are showing improvement. So it's really exciting.
So can you say what doctors are part of the trial? I mean, so I've been enrolling patients as well as you, but if someone
Sure.
on the call or listening later on is not one of our patients, I mean, how do they get enrolled in the trial? What's the best way?
It's sort of a rolling enrollment, and new doctors join. It's pretty easy to join. Um, you and I are in it. Bella Cheddar's in it. Bateman Horn docs are in it. Um, somebody from Mayo is in it, and I don't remember the others, but it's very easy. I mean, if you have a physician who's interested, they can contact me directly, and I will then put them in touch with Dr. Gottschalk, and it's a very easy process.
Great. Yeah, I mean, so I'm finding patients reporting improvement in energy state for sure, even decrease in pain.
Right.
So I think it's an important drug, and we've talked about that. I mean, I love the drug. We've used it for various diseases over the course of decades. It's an old drug. It's not even that new, so we know a
50
lot
years.
about it. Yeah, 50 years, and so
Yeah,
it's yeah.
I had a patient. I mean, anecdotes are always risky, and excited anecdotes are even riskier. But I had a patient yesterday who I've worked with for literally 10 years, and she's just a wonderful person, and I feel like I've gotten nowhere, no matter what I've done. It's been unbelievably upsetting and frustrating. She's pretty much bedbound. Rapamycin is the first drug she's taken where she's told me she has improved energy, decreased brain fog, and decreased pain.
It's
I
interesting because
fell off my chair.
well, now that you say that though, I think that I have noted a more significant improvement in the bedbound patients. And so maybe that's the most exciting part of this, because sometimes the bedbound patients, other than the CCI diagnosis, it's really hard to find drugs that help their symptoms even minimally. So
Right,
maybe
right.
that will, and I agree with you. Anecdotally, we can't make declarative statements at all. So please, interpret this appropriately. But maybe at the end of the trial, when we do some form of analysis, we can sort of decide that this may be the type of drug that bedbound patients will likely respond to, which is what I'm going to cross my fingers
Yeah,
for.
exactly.
So yeah,
Exactly.
absolutely. Okay, so how does ICT bolt testing impact diagnosis, medical management in a suspected CCI patient who is not ready for surgery? So a lot of CCI patients are not ready for surgery, and even when their ICT is, markedly positive, which means that under traction, there's a great improvement of symptoms, and there is an appropriate change of measurements that correlate to the reported improvement of symptoms. Even despite that kind of improvement, patients are afraid of surgery. And I think, David, you would agree with me, I think a lot of it is because there's a lot of chatter, at least on social media, with regards to poor outcomes and or suboptimal outcomes, or that later on, after the surgery, there's, concern for other levels of disease kind of thing that happen. And so they're just afraid to start down that surgical road. And I always say I'll do as little or as much as a patient wants me to. And so I never force someone into surgery. But just to be fair, if there was a truly positive ICT, I strongly advise it, just from what we've seen and what we know. But regardless, as I've said on our episodes, we also do the transcranial Dopplers and the ICT bolt testing. The ICT bolt testing, which was the topic of this particular question, measures intracranial pressure in different positions and over a period of time and under traction. And so it can very well lead to data that can help manage the patient if indeed they don't want to proceed with surgery, because we have levels of their pressure. And so we can obviously trial, so assuming that it's elevated, which is most often the case, though sometimes we do find that there's low intracranial pressure. But assuming that it's elevated, obviously we can trial the drugs that reduce intracranial pressure, such as acetazolamide, topiramate. Sometimes if I use topiramate and Lasix as a combination if the patient can't tolerate acetazolamide. It also gives us other avenues to think, well, okay, well, why is there compression? Likely due to the CCI, but assuming the patient doesn't want surgery, we look for compression, right? So along with CCI often comes jugular vein compression, and there's congestion and backup, and it causes elevated intracranial pressure. So we can look for other anatomical causes for the elevated intracranial pressure, as well as try to manage it pharmacologically. And I have several patients that's what we're doing. If the bolt testing shows low intracranial pressure, low intracranial pressure, one, you go searching for why. So is there a leak? Is there a fistula? And that's a whole topic that we should talk on. I don't know who that was, but okay. Sorry. David, I think I just accidentally muted you. So you can unmute yourself.
That's good. I'm off the hook. I can just shut up for the rest of the hour.
So if there's low, so you do the investigation as to why is there low intracranial pressure. I will say that with CCI, because of the level of compression, there could be obstruction of flow. So occasionally we see elevated pressure in the cranium, but low intraspinal pressure, or vice versa. But regardless, if there's low intracranial pressure, you do want to go searching for, again, reasons, which is especially in the EDS population, but in the chronic illness population, CSF leak is the most common cause. But also we're finding more and more fistulas. It's the kind of thing that when you go looking, you actually find stuff. And I think for many decades, no one really bothered to look for these things. And it can take very specific imaging and a lot of technical components to it, which I don't know how to read for CSF venous fistulas, to be honest. But there are centers that do it. There are experts. There are interventional radiologists. There are neurointerventionalists. There are neurosurgeons that are experts in that particular area. And so I will often refer if that's my concern, but assuming that all the imaging is negative for an anatomical reason, for the reason behind spontaneous intracranial hypotension, it's notoriously difficult to treat, in neurology. That's sort of, the classic training. But some things that can be helpful are certainly bed rest, caffeine can be very helpful, actually, hydration, and then a medication called theophylline, which I do try. And I will say about 20% of patients with low intracranial pressure report improvement in some of their symptoms. The other thing about intracranial hypotension is that, we very often think about these headaches, right? So that gets worse upon standing. Sometimes it's referred to as later in the day headaches, because as you're moving about and you have low pressure, those headaches sometimes don't start until later in the day as the pressure continues to just be, gravity takes over. But over time, though, your body is resilient and has a lot of homeostatic wisdom. And so over time, it sort of accommodates. And those orthostatic headaches are not necessarily a prominent symptom any longer. And that could be, a year or two in if it hasn't yet been diagnosed. So that's just something to keep in mind, that if you have like a long history of headaches, even if it's not orthostatic or positional, there still is a chance that there's intracranial hypotension. And so back to the question, because I think I'm taking too long, because I know we have a lot to get to, but we get this information from the bolting. And so yes, if you don't want to have surgery, based on what the bolt testing shows, there are different measures of what we can do next, and whether that's more imaging to look for a cause or whether that's pharmacologic management, there are things that we can do to manage the patient for sure. Did I take too long on that one?
Well, it's all important stuff. No.
I know.
So there's a posted question related to rapamycin. So since we just did that, my daughter's been bedbound for nearly 2 years. Is rapamycin contraindicated with persistent mycoplasma? It's an important question because it brings up an important misunderstanding about rapamycin. Okay, rapamycin is used for 50 years to help allow patients to get transplants, kidney transplants, heart transplants. It actually transformed transplant medicine when it was finally discovered and put into use. That dose is probably 5 to 10 times higher than is used in this trial and in general for this purpose. The clinical trials in humans with low-dose rapamycin clearly demonstrated an increased functionality and improved immune system, not that they had increased risk of infection, although most doctors hear rapamycin and they think immunosuppression. So it's a key thing to understand. It's another one of these drugs that has this difference at low levels versus high levels, like disulfiram, low level, high level, LDN, etc. So the data is pretty clear. Mycoplasma I would not hesitate to use rapamycin, and in fact, it may even help. And I think this person also asked, "Are you starting a trial?" The trial is ongoing.
Yeah.
And
It's going for
and
a while.
understand you don't even need to be in the trial. I mean, I have been prescribing rapamycin for 18 months before the trial started. So
Yeah, that's an important point, actually. I mean, some patients just want to get started on it
right,
because I talk so highly about it. And as you know, for the trial purposes, you have to get enrolled and you have to do pre-labs. And so it puts off starting the drug. And but obviously, we're looking, we always talk about this. We're always looking to find evidence for what we do. you know, reasons behind our madness, as I
right,
say.
right.
So, I do encourage enrolling in the trial, only because it does provide us with that information that we could go see. This proves what we've been doing has only been beneficial for patients. So, so I encourage enrolling in the trial, but I do have several patients that just sort of didn't want to wait the time to get started. So, and speaking of disulfiram, there was a question that I forgot, but there was
Yeah, there was one here. I remember seeing it.
yeah. Do you want to just talk about disulfiram and how you use it?
Um, sure, it's a completely different topic. It's a big topic.
Okay.
So disulfiram, otherwise known as antabuse, in its usual form is used in a medieval treatment for alcoholism. If the patient takes disulfiram, they get very sick if they drink. No comments on that therapy, okay? In lower doses, it's been discovered I think it's about 5 years ago now, in looking for drugs that might be in repurposing drugs that to see if they would work with tick-borne infections, vector-borne infections. Disulfiram was one of the discoveries. And very importantly, it not only appeared to be antimicrobial, but it was antimicrobial in the stationary or latent phase for Borrelia and Bartonella and maybe Babesia, not clear. That's been demonstrated now in human trials and case report series that have been published. And it can actually be amazingly effective. I've used it in Bartonella a fair amount. Um, you start on a low dose, you taper up. I never go higher than 250 milligrams because that's when a lot of the side effects may start to kick in. And it's been a really important drug because as many of you listening and as many of you know, the problem in vector-borne disease has been the question of why is there, quote, chronic Lyme disease or, quote, post-treatment Lyme disease. And mainstream has never believed that this was an issue. And in fact, it is now absolutely proven that these organisms can be latent, just like a herpes virus 1 or 2 or EBV, reactivate during times of immune disturbance. They can be latent and they can be replicating. And the key discovery in the lab when they did disulfiram is that the usual drugs we use to treat, especially tick-borne Borrelia, Lyme, are not effective against the stationary phase of that bug. And that would help explain why people get better on antibiotics. You stop the antibiotics, and they get sick again as the bug comes out of latency. So.
And I think we did cover this on the most recent episode that posted. So there's more of a conversation with regards to that on that episode. If you have,
Right.
it is a long one, so probably not everyone had a chance to listen to the whole thing, but we do cover that. I should say, you cover it in great detail. So in that episode. Okay, so next question. Does pain control necessarily reduce inflammation? I'm wondering about ongoing low-level pain and inflammation in the brain, headaches and gut, mild stomach aches and gas, often described as background noise, and how it might affect aging, diseases, dementia, stroke. We have LD and Tylenol NSAIDs for the brain and MCAS and SIBO treatments for the gut. If not having digestive problems, is dysbiosis, leaky gut seemingly in control? What are your recommendations for this ongoing low-level pain, inflammation? What about diet or supplement recommendations? Plant-based, reduced red meat, sugar.
All
Probiotic
right.
I don't even know what's
This
that.
this 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 is like what is what?
Akkermansia?
It's a bacteria, a microbiome bacteria in the
Oh,
gut.
okay.
Very interesting. So there's about 1,000 questions here, but they're
But it's
great
an important
questions.
topic. I mean, and I
It's
like the question
huge,
a lot
hugely important.
because, yeah.
So I'm going to start with the easy piece. Does pain control necessarily reduce inflammation? So I I am absolutely sure that pain of any kind causes inflammation and makes people miserable. And you can have low-grade pain chronically and be just as miserable as somebody who has terrible pain intermittently. Okay.
Absolutely.
And pain, this is the key piece, pain causes or can cause mast cell activation and
Mm.
release of all those thousand. I think you upped you upped it to 1,200 the other day in one of our episodes, 1,200 mediators. Um, and so you get into this sort of losing battle where you have pain that causes inflammation, that causes mast cell degranulation. Mast cell degranulation causes pain, et cetera, et cetera, et cetera. So it's a huge issue. Um, and that would be my first answer. Uh, yeah, there's so much here. Um, I mean, interestingly, I don't know if this is somebody that I know, the questioner, but
Yeah.
I use the term background noise all the time. Um, it's an important concept to me because I think it speaks to what's going on with patients in a in a in the sense that often they don't even realize that it's happening because it's just so constant. It's like if you have low level tinnitus buzzing in your ear, during the day you don't usually hear it. Try to go to sleep at night, and bam, all you hear is this ringing in your ears. And that's one of the reasons that measurement tools and studies are so important. Going back to rapamycin, patients may say, "I feel no change whatsoever," but then you look at their answers to the tools, and there's clearly improvement. And that's partly because this background noise. I mean, it improved problems A, B, and C, but D, E, F are still going on, so they lose. It's hard to assess. Um, I don't know if I answered the question there. So with LD and
Yeah, I mean, I think you did a really good job. I mean, and I think all that you say is so true. And I mean, everything is about inflammation. So sometimes I feel like this is an overwhelming topic and it's so complex, right? Because it involves, both the innate and the adaptive immune responses, which is each one of them is very complex in their own right. And so, but we know that aging is inflammation. And obviously a low level of inflammation, we can't stop aging. We're all going to age. We're aging at the moment. So there's some level of inflammation, but to the extent that there's an inflammatory response, to the extent that there's a flare of inflammation is what we need to try to manage. And that's where how our body feels, like, so symptoms in particular are really important, right? So neuroinflammation has obviously a lot of neurological symptoms. Yes, inflammation of the gut has a lot of gut symptoms, though not always, frankly. I mean, sometimes there's an altered microbiome that creates metabolites that affect some other part of the body and cause inflammation from some other parts of the body, like specifically the vasculature. I've seen a lot of vasculitides, and with an altered microbiome, despite the fact that the patient swears that they don't have dysbiosis or dysmotility, and testing would confirm that, frankly. So I think that we have to recognize that it's a very intricate kind of connection between all the different systems of the body, and the best way to approach it is really by a lot of basically what was listed in the question, but also the drugs that we've been trialing. And again, rapamycin has become one of my favorite immunotherapies, but there's quite a few others that I really like, and that really reduce inflammation. And that's what's super critical to it. I mean, there was a recent article in Nature that sort of made its rounds on social media. So I think most have heard about it, but where they found that the brain has its own immune system, and they think they found the part of the brain that controls the brain's immune response, which speaks to the neuroinflammatory response. And it's very much located within the brainstem. And so, of course, that brings us back to what we know about CCI and other kinds of potential connective tissue disorders, and as well as vasculitides, which then ultimately result in poor inflammation of the vessels, which is what that word means. And so poor blood flow, which then speaks to what the question also added as a second part, the microclot theory. And I think that the microclot theory is really one of the more exciting pieces of research that came out of long COVID research, because, you know, if the theory is that if there are these small microclots that are clogging up these small vessels, like the arterioles and the capillaries, that, as I say, feed the crevices of our body, specifically the brain, because it's got all those folds, if you've ever seen a picture of the brain. So it's got a lot of surface area, and every single, you know, like micrometer of that surface area needs to be fed with oxygen and nutrients so that those cells can function appropriately. But if those tiny vessels are clogged up or inflamed, they won't feed it as well, and they'll collapse. And that's what you see when you see these T2 hyperintensities or these flare signals on an MRI. We call that small vessel disease. And now it's seemingly related to potentially a microclot burden, which could, by the way, can come from mast cell activation, which releases some mediators that create a milieu where you more easily form clots. And so, it's a constant work of ours to figure out how we can safely reduce the inflammatory response without just sort of shutting down the immune system completely. And I think drugs like rapamycin and these other targeted therapies that have come on the market in the last couple of years have really made a difference in how we can treat patients. And that's what's been so exciting.
Yeah, I want to add a little bit more. Um, so inflammation, that's a buzzword. It's a little bit overused, probably. It's a little, in my mind, it's kind of like Herxheimer. It's kind of like, oh, you're Herxing. Oh, you have inflammation. And those are true, but they are overused. And I think it's important to keep inflammation in context. We would be extinct as a species without the ability to mount an inflammatory response. End of conversation. Okay. The problem is not the acute response, it's the chronic response. And the evidence for ongoing chronic low-grade background noise inflammation as we get older is overwhelming. And paper after paper after paper demonstrates that that is the cause of the diseases of aging. I would argue that that is also the cause of many of the pathologies and symptoms and disorders that we see in our patients, because they have ongoing chronic inflammation on a similar magnitude, on a similar level as people as they age in their 60s, 70s, 80s. That is precisely why rapamycin might be used. It's precisely why some of these other drugs might be used. It's precisely why you and I, Eileen and I, are so excited about plasmapheresis, which can clean out the garbage, okay, to use a very fancy medical term, which and that garbage, those misfolded proteins and little pieces of this and antibodies and immune complexes all promote inflammation. It's a reason drugs that have a bad reputation in social media, like statins, are such great drugs because they reduce intravascular inflammation. So I mean, we could, you and I, Eileen and I could go on this topic for probably an hour and a half
Oh, easily. Yeah.
because it's just so important. And there's so many interventions that we
Yeah.
know and so many to consider. It's the classic area for trial and error in terms of plasmapheresis and exosomes, and LDN is already an accepted drug, but some of the supplements, uh, uh, photobiomodulation, PEMF. I mean, there's just so many
Oh
things
gosh,
related to
yes,
this concept. So,
absolutely. All,
okay,
yeah, all those modalities I find to be useful for select patients, right? But you never know. Like there's no way to stratify what patient will respond to what intervention.
right,
That's a lot of the
right.
work that we do. It's sort of like figuring out what works best for an individual patient. And that could take a long time, frankly.
So, and to take it a step further, so the inflammation can be linked to or caused by insulin resistance, glucose intolerance, another major cause of aging. That's why the Akkermansia may be very relevant. That's a bacteria that can improve insulin resistance, i.e., decrease it. Um, that's why exercise is so beneficial because it mobilizes various molecules and cytokines, which ultimately reduce inflammation. So.
Right. And we always talk about how most of our patients have a hard time exercising to get to that level, which is why, by the way, the semaglutide class of medications is showing to have a lot of great
Right,
effects and benefits outside of weight loss and diabetes control. And
right.
I also think that we don't talk about, not you and I necessarily, but I don't think there's enough of a conversation in our chronically ill patients with regards to glucose dysmetabolism and insulin resistance. I think that this metabolic syndrome kind of idea, which I think needs to be better defined because I've never been happy with its definition, but I think we need to sort of we need to study that more in our patients because I think it's playing an important role because glucose is such an important molecule for energy, right? For all organs. And so I think that's something that, and I think that that's why we're seeing with the GLP-1s, we're seeing some improvements, or at least I
Mm.
am. I don't think you and I had that specific conversation yet, but I have been giving some of my patients the GLP-1s and they do have improvements. So I think that and then it's not all about, weight actually. So,
Well,
yeah,
on yeah, on Masterminds, our online thing, there's been anecdotal, discussions where low dose semaglutide is showing benefit as a mast cell agent to decrease mast cell activation.
yeah.
That's incredible.
I mean, it's exciting actually. It's
Yeah, yeah,
exciting. If only the insurance companies would get on board because I'm having a hard time getting approvals.
yeah. I don't even try. Just go for compounding.
Right. Yeah, you can do it that way too. Okay, can a pain med such as gabapentin continue to cause neurological paresthesias, bone aching side effects for years following its discontinuation? Because the side effects are neurological in nature, does that signify a mast cell response? If so, why would mast cells continue to be engaged and what mechanism is involved? If not, why would a drug continue to cause continuous neurological and only neurological side effects years later? Interesting. So if you're referring to a pain med such as gabapentin, which is the example that this person gave, it's specifically for neuropathic pain. So if you were to have worsening paresthesias, for example, then you had what's referred to as a paradoxical response. So, gabapentin controls some of the channels of the cells. So it doesn't engage in the GABA receptors. And I made that point in one of our episodes, but it actually controls one of the channels of the cells. So we have different channels that makes our cells function and it lets ions in and out. There's calcium channels, there's sodium channels, there's potassium channels, and so on, which means that your channel responded paradoxically to the gabapentin. And so sometimes if you have an underlying channelopathy, which is an interesting topic in and of itself, because I am finding in a small set of patients that they have variants of channelopathies, of which there are many in neurology, and anyone can Google channelopathies and see what they all are because there's many. And that's a whole episode in itself, as I said. But I'm finding that some of them have variants to channelopathies, which means that sometimes they would respond inappropriately to any medication that has an effect on that particular channel. And so that's one thing to think about. Can it be a chronic mast cell response? Absolutely. So mast cells line the nerves. Mast cells are in all connective tissue, so even bone aching, which was one of the side effects that was put in the question. Bone is its own connective tissue, so there are mast cells everywhere. They're in every piece of connective tissue, which is truly our entire bodies. So there could be a chronic mast cell response for sure, because they're all around the nerves and all around the bone and just all around the body. And what would that mechanism be? So, like with regards to mast cell activation in general, there was a trigger that set off the mast cells, and then some of those mast cell mediators are actually they have an autocrine kind of effect where they turn around and trigger the mast cells again and just keep poking the bear, and so sometimes that's what's going on. It's just sort of this, automatic kind of mast cell degranulation activity. Sometimes whatever the mast cell has created in terms of degradation of other kinds of proteins in the body, those degradation products can trigger the mast cell response. And then also just honestly, like, we say this all the time, we're exposed every day to something. I mean, the air we breathe, the water we drink, the food we eat, the products we use, they are all exposures. And if we have a sensitive constitution, or we've been chronically ill, and our inflammatory response is in a state of perpetuity, then those mast cells just don't know how to relax, and they're in what we refer to as the cell danger response, and they get stuck in that cycle. And there's 3 phases to the cell danger response, and they get stuck in what we think is stage 2, but they don't know that danger is gone. And so they don't come out of that cycle and just relax. And that's a problem, because in the cell danger response, the cells sever their ties with their neighboring cells, and so they don't talk to one another. But that communication is critical for organ function. And so if the mast cells just think that there's danger afoot, they don't want to talk to anybody. They want to hunker down and get ready to fight. And so that works against, the body's homeostatic mechanisms. And so that, again, I don't know this to be 100% accurate in terms of the answer to your question. This is what some of the research will suggest. This is what I believe to be true. This is what I've seen. And I know for a fact that when you have a paradoxical response to a medication, there's usually some prolonged effect, just because of the body's response to what that medication's mechanism of action was. And so I have seen that many times in my career, where a drug I gave for a particular symptom either caused another symptom that we couldn't get under control, or made that symptom worse. So that is clearly, obviously not, our goal, but that is, so my thoughts on that question. Dave.
You covered it.
Okay. Fatigue. So fatigue is a whole episode. She asked, actually, would the causes, mechanisms, and treatments of fatigue be enough to fill an episode? Oh, I would say it would. Probably more than one.
Right.
So maybe we just say fatigue as a topic. Fibromuscular dysplasia is a connective tissue disorder. It's my opinion, right? So there's these dissections. I mean, what else can be? We call it idiopathic. I know that, it causes a lot of morbidity and mortality even for some, and it most commonly happens in women, and they usually present with a dissection of vertebral arteries, carotid arteries, but dissections of vessels are connective tissue disorders. And so I think it's all one and the same. And so I think that these chronic conditions, if you have a diagnosis of fibromuscular dysplasia, you have to treat yourself like you have a connective tissue disorder. And that's just generally the work that we do for our EDS patients, and so it overlaps a lot.
So this question is, they're saying if someone has a tortuous carotid artery, I'm not sure if they're saying, therefore, they have fibromuscular dysplasia.
Oh, yeah.
I'm not sure that's the same thing at all. What?
I thought that was part 2 of the question. Yeah, I don't think.
Oh, maybe it is. Okay. All right. And what I would say here so it says, and if someone has this tortuous aorta, would you follow this trail before evaluating and treating possible cervical instability? There's never just one reason, okay, one thing, and I would not. I would try to look at the whole picture and get a clearer picture of what's going on, and follow more than one thing at a time. Otherwise, we'll never get finished taking care of patients. I mean,
Right.
I think we need to go on parallel tracks when we do this.
Yeah, no, I mean, yeah, you have to do everything at this, most things at the same time. Otherwise, you're right. Then it's just, I feel like I'm just constantly adding on. I'm like, okay, now we have to do this. So I think that could be frustrating for a patient, also frustrating for us because we want
It
answers as well, for the
yeah,
patient.
yeah.
So yeah, I agree. I think, tortuous vessels, um, radiologists love to report them and they act like it's just incidental because they'll look patent, which means they look like the blood is still getting through. So it's just that it's twisting and turning. But because of the work that we do and all the imaging that I've seen over the years, I do believe that it's something, and there's nothing that can be done about it. I should just say that, right? I mean, there's no surgery that I would recommend that would do more good than harm for sure. And so the goal is to try to optimize blood flow. And as I've already said about the microclot theory, which I found really fascinating from the long COVID research, but also with the data we collect from the transcranial Dopplers during ICT, a great percentage of chronically ill patients have low cerebral blood flow velocity. I think tortuous vessels really hold a place for reason for treatment of that. Like, so optimize blood flow. So you can use blood thinners, of course. You can exercise, as David said, is a really great means of trying to increase blood flow. You can use certain medications that help to make sure that the blood stays in the brain. So vasopressors, for example, and so that there is less, so if there's less reason for gravity to take it out of the brain, which, happens in a lot of hypovolemic kinds of POTS events. So we use a lot of those vasopressors to sort of keep the blood up in the brain so that it can counteract the gravity that takes hold. So there are things that can be done, none of which are magical or, really seem to solve the problem completely, but certainly some that at least minimize the symptoms that are related to poor blood flow, of which tortuous vessels is a component of that, right? If you think about, I mean, take any pipe, right? And if you twist, although I guess pipes are metal, so you can't twist them as easily, but I think you guys know what I mean. you
So
know,
I'm
mhm.
sorry, Alan.
Oh, go ahead.
No, I would just add that it's a useful question to discuss a general topic, which I think is important to understand, and that is in the body and in the circulatory system, anytime, anytime there is slowing of flow or stasis, meaning it sits still, or even turmoil, meaning it's not flowing in a nice, neat river, but it keeps hitting rocks and there's splashing and all that kind of thing.
That's a good analogy. Thank you. My pipe wasn't a very good one.
Um, there is a significant increased risk of blood clots. And whether we want to call them microclots or sticky blood or sludgy blood or massive emboli, it doesn't matter. It's a risk. So it's a risk in tortuous aortas, especially the carotid feeding the brain. It's a risk in pelvic and abdomen venous compression syndromes, which I think we've talked a little bit about, and I'm sure we're going to be talking a lot more about. You don't need, a lot of the radiologists will say 60% less than 60% stenosis, therefore not a problem. Well, how does the radiologist know that? I would argue it probably is a problem.
Right.
60% is more than half of the blood vessel is screwed up. Okay. So I would even go and argue that when we do transcranial Dopplers, and we now know that I forget the latest statistic, I think it's 30 to 40% of ME/CFS patients have a reduced perfusion to the brain. That means there's a decreased flow of blood. That means there may be increased sticky, sludgy clot blood, and that may be further increasing the lack of oxygen and neuroinflammation, et cetera. So it's actually a huge issue. And it needs to be approached carefully because we're not going to go around just casually anticoagulating everybody, but there are lots of ways to try to address it.
Yeah, I completely agree. And I think it's an important component of an overall treatment plan because, every organ needs blood. So, um, what vasopressors in your clinical experience provide the best benefit? Um, Well, I mean, so the most common letter I use, imidodrine, fludrocortisone, um, and I think that's what most will use. Sometimes I'll use droxidopa, which is Northera. Do you use the same, David?
I'm sorry, I was reading a question. Say it again,
Oh,
Eileen.
sorry.
I'm sorry.
No, what are your favorite vasopressors?
Oh, well, droxidopa is great, but getting it approved is a
Yeah,
nightmare. So that's the usual. American answer.
Right.
Um, so I use mitogen, which is easy to use, has some side effects as the dose goes up.
Mm.
Um, fluids, 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 salt, 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 electrolytes. Um, I I I often will use, this is not quite answering your question, but so to me the question is not so much pressors, it's what's the problem?
Right.
And often the question is it a vascular volume problem versus everything else? And and I think vascular volume issues are huge and frequent and common. So if the patient if we're not getting anywhere, sometimes a trial of IV saline for a couple of weeks may help explain what's wrong, because if they feel better after each infusion, then it's clearly a volume issue to me, and we need to ramp up the volume drugs, which you don't think of as pressors, but they are pressors because by increasing volume, the blood
Right.
pressure improves. So fludrocortisone, desmopressin or DDAVP, mitogen, I already said. Beta blockers, I don't think of as pressors. Actually, if you push the dose that drops the blood pressure, it can act like a pressor in the sense that if you improve the rapid heart rate, the cardiac output improves, and then the pressures go up. Similarly, guanfacine, not a pressor per se, but can improve perfusion. So I
Yeah.
don't use, yeah, right. So those are the ones.
Right. I agree. I mean, I really like Northera when and if I can get it approved. I try to limit the amount of fluid that patients take in because it can have a real drastic effect on blood pressure. So I just say sort of limit the amount of fluids you take in and start the Northera and monitor your blood pressure for 2 weeks, and then assuming I've gotten it approved. But but just to make sure that their blood pressure doesn't like precipitously rise, because I've seen that happen, and so that's just one thing that I'll add to the Northera, the droxidopa. But I very regularly will use a combination of midodrine. I actually dose it 4 to 6 times a day in low dosing, just because I think that's a little bit safer, and I also use it with fludrocortisone because fludrocortisone, as you know, increases the intravascular volume. So and then midodrine works on the vascular resistance. So I think that the 1-2 punch at low dosages, I think sometimes is more effective than one at higher dosages for patients. But again, it's all individual. And I'll repeat, this is not medical advice or guidance. And please don't go running to your doctor and say, Dr. Ruhoy said to do it this way. But these are just things that are in my head when I'm working with patients. But so, okay. Um, that's my big fear, is that like, doctors across the country are gonna like hate me for like things that I say and patients will repeat it. Um, okay, so is
So
there,
that,
I'm sorry, what?
yeah, I want to go to this question here.
Okay.
Is there any risk? I think you were about to do it. Severe GI side effects with low dose GLP-1s, which are semaglutide. Um, so it's a really important question for the following reason. So one of the mechanisms of weight loss caused by semaglutide and company is decreasing gastric emptying. Okay, so the food you eat stays in your stomach longer, so you feel full, so you eat less food. It's not rocket science. Okay, the concern I have, going back to what you and I, Eileen, talked about, that we're excited about the effect of semaglutide on lots of other parameters unrelated to weight gain or weight loss, is that so many of our patients have autonomic dysfunction that they already have a motility disorder, and using these drugs may worsen that problem. So it's a big concern. And I frankly don't know the answer whether low dose would avoid that motility, that drug-induced gastroparesis, but still get the benefit. I think we need a
That is an
trial to look at
interesting,
that.
really interesting question that I didn't think of this until you were just saying that, is that on the patients that I have prescribed one of these class of medications, most commonly Ozempic, but I've done some of the others, they will report to me that they have no symptoms of the low dose. We increase to the higher dose, which is the protocol. They get often significant GI symptoms, but that's where the weight loss happens.
Right,
And then so they on their own, they go back down to the low dose where those GI symptoms are gone, but the weight loss stops.
right,
So I do wonder if like our patients should just be on a low dose and just sort of stay there, which is what I've tried to do when I first started prescribing them, only because they weren't, they were not a neurology drug. So I didn't have all that big of a comfort level initially. So I would try to keep them at the low dose and just sort of see how they did. But Then I got more comfortable and I let them go to the higher dose. But it was interesting that that's when the side effects, the GI side effects occurred, and the weight loss also occurred. And then when they went back down, the weight loss stopped, but so did the GI side effects.
Right.
So that's an interesting anecdotal.
Right. So we need a trial, and
Yeah,
trials, in our business can be 10 patients. It doesn't need to
that's
be
right.
500 on and 500 placebo. So think of it as a pilot trial, and it can be done within one's own practice. I mean, frankly, that's how I got into rapamycin. That's how I got
Yeah,
into oxaloacetate.
right.
Start in your own practice, full disclosure to the patient, et cetera, et cetera. But that's how we learn.
Yeah,
It may not be what mainstream medicine does, but as we say, we're long past mainstream medicine. We need to take care of our patients.
absolutely.
So it's a great question, and I hope maybe 3 live streams from now we can give an answer.
Yeah, no, that would be great. I think we should do our own little trial, actually. We
Right,
should talk
right.
about that. Um,
Uh,
I like this question. It was before we just skipped it. I had months of glucose dysregulation seen on CGM, which is continuous glucose monitor. When inadvertently exposed to high level of mycotoxins, I reacted with intense vomiting and diarrhea. And after this acute purge, my glucose dysregulation ended. This seemed to suggest a GI connection to my glucose dysregulation. Could there be an alternative explanation? That was my phone, sorry. um, so I guess the question is about mycotoxins that cause vomiting and diarrhea, and then
no, I don't think it's that. Yeah, yeah, right, right. So I think what she's asking, or this person's asking, is they had glucose dysregulation, then they got really sick with GI illness, nausea, vomiting from mycotoxin or whatever, and now their glucose intolerance is better. I think that's the question.
yeah, I think so
It's a
too.
great question. It's really interesting.
Yeah,
It always, this kind of question always kicks off the thought that I've had patients tell me, who have all their stuff going on, that they go for a screening colonoscopy, and they do the prep, which is a total unpleasant experience, and then they feel remarkably better. Right?
mhm,
Even though the prep is what's supposed to be make everyone miserable, after the prep, after the colonoscopy, they wake up and for days to weeks they feel better. And I think that's partly a change in the microbiome and a change in what's leaking across a leaky gut. And that may be partly what this person has, experienced, although I don't know how else to measure that or prove that. But we know there's a clear GI connection between glucose levels in the blood and what's going on in the gut. I mean, that brings
right,
us back to Akkermansia and
absolutely. What you started
semaglutide
about.
and everything.
I do want to go to this one question that was posted on Patreon at the initial post with regard to this live. I was diagnosed by Dr. Bolognese with severe horizontal CCI, severe jugular compression, one side severe and the other mild, and decreased absent CSF flow due to mild tonsillar herniation. I'm trying to decide whether or not to have fusion. My question is, can any of these conditions cause brain atrophy and or white matter lesions more than appropriate for age? I've been through many workups with various neurologists with no answer for these issues. And also being caught, and she has refractory celiac. Dr. Bolognese noted diffuse supratentorial atrophy on his report. Um, so the answer is yes. um, so can celiac, though, to be fair, right? So we know that, in fact, I've had a lot of patients not know they were celiac, but come for neurological concerns. And we found that they've had celiac probably for decades and just did not know it. No one tested them for it. Didn't have, interestingly, they didn't have prominent GI symptoms. And celiac can do that, frankly. Celiac can actually cause a very potent neuroinflammatory response. There are no diagnostic markers on an MRI that says, "Oh, this is celiac," which is the problem. Though there's no great answer for that problem because a lot of things can present in a similar fashion when we're talking about brain MRIs. Um, so I always think it's important to test for celiac whenever there's chronic neurologic symptoms, and I think that's an important point that I'm glad that this patient made me think to say that that you should be tested for celiac if there are chronic neuroinflammatory kinds of symptoms for sure, because celiac can certainly present that way. But with regards to the CCI, the jugular compression, the absence of flow from tonsillar herniation, that can absolutely cause atrophy because it impairs blood flow, it impairs CSF flow. and that impairs glymphatic function. And anyone who knows me knows that I talk about the glymphatic system all the time because it is such an important system to basically rid our brain of all the foci and all the fodder that causes a neuroinflammatory response. It happens most effectively during restorative stages of sleep, which, as we know, is a common problem for many of our patients. They have sleep dysfunction. Um, so, so there's a lot of issues that need to be addressed because we need the glymphatic system to be really effective and efficient in order to rid the brain of abnormally misfolded proteins that love to accumulate in the brain, which cause an intense neuroinflammatory response, which underlies a lot of cognitive decline. It rids the brain of metabolic waste byproducts and cellular debris from all the different enzymatic reactions that go on in our brain. Our brain is one of the four most metabolically active tissues in the body. I would argue the most metabolically active. But the four are the brain, the heart, the optic nerve, believe it or not, and then muscles. But the brain is up there, and so we need to clean it. And so that's the glymphatic system. And so all of that anatomical problem at that cranial-cervical joint, which is squeezing, especially with the tonsillar herniation, is squeezing not only the jugular vein, but the brainstem, is probably the carotids as well. So it's just impairing all of that function going on. So it can absolutely cause some atrophy. To the extent that it does. Again, it's, I've seen patients where their brains, their MRIs look incredibly normal, yet they're incredibly sick. So I always say that I think we rely a lot on imaging, and I'm not sure we should do so because there isn't always a clinical correlate. And radiologists love to say, found this clinical correlate is warranted. And it's an important statement because sometimes we see, I look at a brain MRI and I'm like, I don't know how you're working. And sometimes, patients cannot work and yet their brain MRIs look just fine. So, so there's a lot, I guess if these are complex questions and there are complex answers, but yes is an answer for sure. So just something to think about when considering the surgery.
I would just add and underline what you said about the imaging. I see a read of atrophy often, and you're the neurologist, so you may disagree, but I think that's an overread, and it's a terrifying word for a patient to hear because it immediately raises the question of, am I getting demented or dementia or Alzheimer's or something? And I'm not even sure on imaging that you can determine whether the atrophy is a fixed anatomical change or, this is crude statement, or dehydration in the brain, that there's altered perfusion, there's hypoperfusion, and it looks in the imaging like atrophy, particularly if the patient, like this question, the person asking the question, what is their functional neurologic capacity? How are they, right? How
Right.
is their executive function? Can they do the tasks and stuff? Because so often those findings don't correlate with the real life. It's
Right.
like, all the MRI back disorders you see that in
Oh
people who have
gosh,
no
yeah,
problem. So
absolutely. Absolutely.
that's none of what I just said is any reason not to pursue celiac, CCI, and fixing everything.
I agree with all of that as well, especially when it's been diagnosed. Like if you hold those diagnoses and you have symptoms that are consistent with those diagnoses, and you have imaging that could be related to those diagnoses, you absolutely need to treat. And I do really advocate for that. We always say that, the best medication in the world won't fix an anatomical problem. And so sometimes surgical intervention is really the only option. And it's not always a fusion, right? If there's jugular compression, sometimes I recommend starting with the decompression, which is an easier surgery to a large extent, actually. So there are ways of managing things, and I think that's important, though. But my goal is to try to get people to fear less these surgical interventions because I think that's a big concern, especially and when they're indicated. Obviously, I mean, if it's not indicated, then it's not even a
What
concern.
actually one more point to add to all this. So let's say the atrophy is real, meaning it's not just an overread, and let's say it's significant atrophy. And let's even say the patient has some impairment from that. That is still not a reason not to pursue treatment because you can perhaps treat the cause of the atrophy and stop it from getting worse.
Absolutely.
And the brain is a remarkable organ, despite what you and I were taught in medical school, that it never grows new neurons and everything. It recovers.
It
There
does.
has an enormous degree of plasticity. And
Yes.
if you remove the offending, insulting agents, it can recover, or it can at least stop getting worse. So
That's an excellent point, David. I mean, there's no doubt that neuroplasticity lessens as we grow older, but it still exists. And we have neuroprogenitor stem cells in our brain all the time. We're making new ones, the brain makes new ones, and they're all poised, ready to regenerate for for any kind of neuronal demise, right? And yes, the activity of that is different when we're 20 versus when we're 40 versus when we're 60 and 80 and so on. But the activity is it's still possible. Let's put it that way. There's still a possibility, but you have to remove the offending trigger, and whether that's an anatomical problem or an exposure problem, like an infection, for example. And I've heard of reports from other doctors like yourself, Dr. Kaufman, that they've done post-mortem biopsies on brain and have found, certain organisms, specifically those of the tick-borne form. So that's always fascinating.
character
Yeah.
of the tick-borne persuasion.
Which I learned just recently from you that they're not all spirochetes, which is somehow what I believe them to be. I don't know. So I'm becoming an infectious disease expert. So, all right. So I think that's, oh, our time is up. Wow, that went really, really quick. And there are so many good questions. Um, but alas, we have to end. We will, a lot of these questions are really good ideas for episodes. And maybe we actually also just take an episode where we answer questions again. We've done that in the past, and maybe it's time to do that again. And so we're learning more and more all the time. I mean, I think there's a lot of really fascinating research, and we always say we learn more from patients than we do from anything else, really. And that continues to be true. I've learned so much from patients in the last bunch of weeks, and I'm excited to talk about different topics that came to my mind working with these patients, as I know that you are, David. So we thank you for your support and for being a subscriber. And we hope to continue to do this for a long time to come and provide lots of great information. And please tell your friends and your doctors, and tell your doctors we're not crazy. And thank you for giving us your Saturday for an hour. So have a
Thank
great
you.
weekend, everyone. Bye.